Thank you all for joining, and I will now introduce our speaker for today. Dr. Schwartz's clinical and research interest is the treatment of acute lymphoblastic leukemia, ALL, including T-ALL and B-ALL. During his resident and fellow training programs, Dr. Schwartz was comprehensively trained in ALL treatment. Since joining University of Colorado Hospital in 2020 as a clinician, his focus remains on the clinical treatment, clinical trials, and research of ALL. Thank you, Dr. Schwartz, for being here today, and I will pass it over to you.
Okay, thank you. Thank you very much for that introduction. Oh, sorry. Can you see the slides or?
We see your editing view.
Okay, okay.
Great.
Everything looks okay now?
Yes.
Okay, great, thanks. So thank you so much. So I'll be talking today about adult ALL, which is kind of been my clinical and research focus, and talk specifically about a clinical trial that was developed here on campus using a novel CAR T-cell therapy that was developed on campus at the Gates Institute. Just some basic background on ALL. So ALL is a blood cancer. It's one of the two types of acute leukemias that occurs in adult patients. The more common form of acute leukemia in adults is AML, or acute myeloid leukemia, but acute lymphoblastic leukemia, or ALL, occurs in children as well as in adults. There are two main types of ALL that are kind of distinguished by the lymphoid precursor that becomes cancerous. So there's B-cell acute lymphoblastic leukemia, which is the predominant subtype, occurs in about 75 to 80% of ALL patients, and then T-cell ALL occurs in about 20 to 25% of cases. So the peak incidence of ALL does occur in very young children around the ages of 3 to 4 years old. After that initial peak, there's a decline in incidence throughout the teenage years. There's a kind of a small uptick in ALL cases that occurs around 20 years of age, followed by another decline in incidence through the early adult years, a nadir in incidence around 40 years of age, and then a second uptick in the incidence of ALL when we get into the older adult age ranges, 50 and 60 years of age and above. And that increased incidence in the later years is mainly due to a specific type of ALL called Philadelphia chromosome positive ALL. So across the age ranges throughout pediatric and adult patients, one thing that's pretty remarkable is the disparate survival outcomes between younger patients and older patients. The treatment of pediatric ALL has really been a pretty remarkable success story with prior to the development of the first chemotherapy drugs. This was really a disease that was incurable, to now, over successive generations of clinical trials, pediatric patients with ALL now are generally predicted to have an over 80% chance of cure with just chemotherapy alone. As you get up into the higher age brackets, the overall survival of patients with ALL does gradually decline. And that's partly due to a more adverse disease biology in adult patients. And also, a key component is a lower tolerance for the types of intensive chemotherapy regimens that younger patients can often tolerate a little bit better. So the general principles of treatment of a patient with ALL, there are three main phases of treatment. The first phase of treatment we call the induction phase, consists of multi-agent chemotherapy between 3 and 5 chemotherapy drugs, which are given over usually about a 4 to 6 week period. And the goal of induction is to get a patient into a remission. Once a patient's in remission, typically chemotherapy is continued throughout what we call consolidation or intensification phases over approximately another 4 to 8 months. And this phase consists of more multi-agent chemotherapy given over various different schedules. Finally, the final phase is the maintenance therapy phase, which typically lasts about 1.5 to 2 years. This is maintenance is generally more chemotherapy, but of lesser intense chemotherapy, mostly oral chemotherapy, pills that patients can take at home, and can mostly kind of avoid coming back and forth to the hospital once they're in the maintenance phase. So, what do we know about sort of the treatment of adults with ALL and kind of what's the expected outcomes? So we know that induction therapy typically produces a very high rate of complete remission, around 90%. However, once patients are in remission, typically about half of those patients will ultimately relapse. And traditionally, relapse ALL has had a very low rate of response to traditional chemotherapy agents. And even when responses are achieved, they typically are of a pretty short duration. So, if we know that about 50% of patients will ultimately relapse who achieve initial remission, how do we sort of risk stratify these patients and predict, which patients are most likely to relapse? And so there are a number of different factors that we look at, but probably the most important predictor of relapse in both pediatric and adult ALL is what we call minimal residual disease. And this just refers to testing methods that are highly sensitive and are capable of detecting very low levels of leukemia that we often cannot see just by looking at a patient's bone marrow under the microscope. So many different studies have been done looking at the impact of MRD on outcomes. A very large meta-analysis was published in 2017, looking at hundreds of adult patients with ALL and comparing outcomes for patients who are MRD negative versus MRD positive. And what they found was that the 10-year overall survival for adult ALL patients who were MRD negative was significantly better at 64% versus 21% 10-year overall survival for patients who are MRD positive. So, what can we do for these patients who are MRD positive during chemotherapy, who we sort of know are destined to ultimately relapse? And one intervention that's been shown to be beneficial for those MRD positive patients is an allogeneic stem cell transplant. So this is a therapy, an allogeneic stem cell transplant, where essentially We are eradicating a patient's bone marrow and immune system and giving them a new blood system and immune system from a donor. And as you can probably imagine, that is a very intensive therapy. Not all patients are eligible for a stem cell transplant. However, typically younger and healthier patients are eligible for a stem cell transplant if we determine that that would be beneficial for them. So, the therapeutic landscape for ALL has really evolved quite a bit over the last 10 years. So for a very long time, the effective therapies that we had were chemotherapy and allogeneic stem cell transplant. But really, a number of novel immunotherapies have been developed that have really changed the treatment landscape recently. And one of the most important therapies that's been developed is CAR T cell therapy. So CAR T cell therapy is basically engineered cell therapy. We basically engineer a T cell to express a receptor that recognizes an antigen that's on the surface of the target leukemia cells, which in the case of ALL, the target is CD19. And that antigen binding moiety is connected via this transmembrane domain to a T cell signaling domain, which is on the interior surface of the CAR T cells. So, the first CD19 CAR T cell therapy was initially approved for pediatric patients in 2017. And since that time, we've really gained a lot of knowledge and experience around the use of CD19 CAR T cell therapy in both pediatric and adult patients with relapse refractory B-cell ALL. And what we found across the age spectrum of pediatric and adult patients is that CAR T cell therapy produces a very high rate of complete remission, and often those remissions are very deep or MRD negative remissions, on the order of 60 to 90% of patients will achieve a deep remission after CAR T cell therapy. But when it comes to kind of the long-term outcomes after CAR T cell therapy, there's a little bit more disparity in the outcomes between pediatric and adult patients. So we know that pediatric patients who are treated with CAR T cells, the majority will achieve an initial remission, but about 50% of patients will ultimately relapse. And the majority of those relapses will occur in the first year after CAR T cell therapy. But that means another 50% of patients will go on to achieve a long-term remission without any additional therapy after the CAR T cells. In adult patients, the duration of response tends to be a little bit less than what we see in pediatric patients. So although the majority of patients will achieve an initial remission, probably only about 20 to 25% of adult patients will remain in a long-term remission with just CAR T cell therapy alone. So the majority of patients, despite achieving a remission, will eventually relapse. So we have this very effective therapy now, CD19 CAR T cell therapy, that we know is very effective in producing remissions in pediatric and adult patients with heavily pretreated relapse refractory B-cell ALL. And we know that the short and the long-term side effect profile of CAR T cell therapy is generally pretty favorable compared to more toxic intensive chemotherapy and stem cell transplant. So kind of the natural question then is, can we bring CAR T cell therapy up earlier into the treatment landscape and try to give these patients this effective therapy before they've relapsed and incurred toxicities of multiple lines of therapy. And sort of the rationale there for kind of moving this therapy up is kind of threefold. Number one, we know that before patients are heavily pretreated and multiply relapse refractory, their T cells are generally considered more fit and thus potentially more effective in terms of targeting the leukemic cells. The disease is less resistant. And by giving the CAR T cells in the frontline setting, we're basically, after patients are initially in remission, we're giving this therapy at the time when patients have a very low disease burden. And what we found in the relapse refractory experience is that when patients have a low disease burden pre-infusion, they generally have better long-term efficacy, meaning lower risk of relapse, and lower expected toxicity from the CAR T cells themselves. And then specifically, in adult ALL patients, kind of another question that we're hoping to address by moving CAR T cell therapy into the front line is, can we overcome the poor prognostic significance of MRD without subjecting patients to the toxicities of an allogeneic stem cell transplant? So in order to address these questions, we designed a phase 1 study of UCD19 CAR T cells, which is a CD19 CAR T cell product that was developed here on campus at the Gates Institute. And this trial is a trial that's studying adult patients with B-cell ALL who are in their first complete remission but have minimal residual disease positivity. So this is a 10-patient phase 1 study. As a phase 1 study, the primary objective is safety of this, of the CAR T cell therapy for adult patients with CR1. So primarily, in terms of measuring safety, we're looking at adverse events and dose-limiting toxicities. So this is a dose escalation study with 2 dose levels, and dose escalation is per a Bowen design. And then secondarily, we're looking at preliminary efficacy of this novel therapy in the frontline setting. And the endpoints that we're looking at there are MRD negativity at 1, 3, 6, and 12 months post UCD19. And then event-free survival and overall survival at 12 and 24 months post UCD19. So this study opened to accrual in June 2023, so about a year ago. So far, we've enrolled 7 patients on the study and have treated 6 patients. So far, what we can tell so far in terms of safety, so 4 patients have completed the DLT monitoring period, and no DLTs have been identified amongst those 4 patients. And in terms of preliminary efficacy, so the first 2 patients are more than 3 months out from treatment, and those 2 patients remain in an MRD negative CR at 3 months. Subjects 3, 4, and 5 are a little bit earlier post-infusion, but they've all had their 1-month post-infusion assessments and are in an MRD negative CR at 1 month post UCD19. And so, our next steps are we're looking to present our preliminary data at this year's ASH, or American Society of Hematology meeting. We think the data is so far very compelling in terms of safety, preliminary efficacy, and it's a pretty novel study that is not really being done anywhere else in the US. And since we've accrued the study so rapidly, we're also looking at designing a dose expansion cohort of additional patients with the primary objective of determining efficacy of UCD19 for MRD positive ALL and CR1, and comparing that efficacy to historical controls. And with that, I want to thank everybody so much for your attention and the invitation to speak, and I'm happy to answer any questions.